In the third line setting, we often think about what is the best way to sequence the drugs. And I think this is obviously a huge challenge, and we really don't know what's right. And these are some of the active studies and areas of interest, of research interest at this time, in terms of what will provide the best tolerability, best quality of life, but then, of course, also prolonged survival. What we do know is that patients that are RAS wild type that have not received anti-EGFR therapy up front often then, in the third line setting, initiate either cetuximab or panitumumab with or without irinotecan. We often try to include irinotecan because we know that the data are better with the combination. Beyond that, of course, the MSI high population benefits from immunotherapy, so that's certainly now an option which is FDA approved, albeit it's a very small population, only about 2 to 4% of our patients with metastatic disease. With regard to choosing between regorafenib and TAS-102, very little is known. There is, in the original TAS-102 study, about 114 patients did have prior exposure to regorafenib, and they still benefited from TAS-102. So this suggests that that sequencing could be regorafenib followed by TAS-102 without actually compromising the efficacy of TAS-102. It was not, it was retrospectively reviewed, so we don't know if this can be extrapolated, but it was about 17% of the patients, and clearly there was still a benefit with TAS-102 over placebo in this population.
When we face patients who are in the third-line colon cancer setting, who are microsatellite stable, and have been through FOLFOX, FOLFIRI-based regimens, the approved FDA drugs include TAS-102 and regorafenib. Choosing between one or the other is somewhat arbitrary because there isn't really any data to support one before the other. They're both approved and used in similar settings. There are certain people who prefer one or the other based on toxicity profile or based on biology, but at the end of the day, both TAS-102 and regorafenib are approved for those indications. We talk to patients about the different toxicity profile between the agents and what to expect. I would say perhaps the majority of patients do start with TAS-102 before regorafenib in most people's institutional practices, although it really differs. And some data presented at this year's ASCO GI would suggest that maybe starting earlier with regorafenib might be biologically indicated, actually. But we need some more data to truly answer this question. When we're talking to patients about which drug to choose, we also talk to them at this point, obviously, about participating in clinical trials, which is a very common thing that third-line colon cancer patients do, whether they're immunotherapy combinations, of which there are many, as you can see at this year's GI ASCO, many of which are being studied in this space, or looking at alternative strategies to combine other medications at this point is something that everyone is looking at really closely.
For patients who are MSI high and would go on a PD-1 inhibitor, pembrolizumab or nivolumab, those patients typically do extremely well. There's a small percent of patients that tends to progress a little early, but the majority of the patients progress much later. Most of the patients that have done well on one of the PD-1 inhibitors in my clinic with MSI high tumors have actually continued to do well and continue to do well, and have had very few progressors. However, for those patients who do progress, in the absence of a clinical trial that looks at immunomodulation and trying to rekindle the response to PD-1s, or essentially using other immunomodulatory agents, I would go back to the standard, or our standard of using regorafenib and TAS-102 sequentially. So those patients would still benefit from the treatment options that otherwise the non-MSI, so the MSS patients would benefit from.